Welcome to AETCM, the emergency medicine channel. Today let us discuss about palpitation, one of the most important symptoms by which patient can present to emergency room. Palpitation is very common. It is defined as unpleasant awareness of forceful or rapid beating of one's own heartbeat. Uncomfortable awareness of our own heartbeat. Normally we don't feel the heart is beating. We don't get that feeling at all in a normal person, but when we run or when we exert, we can see that our heart, the feeling of heartbeat we can feel. That is palpitation, but that is physiological. But there are some conditions where the patient is absolutely normal, no other clinical finding. Suddenly patient develops severe palpitation. It can be due to stress, strain, fear, anxiety, and other physiological conditions like pregnancy, various pathological conditions, heart diseases. So many reasons are there for palpitation. Some are very benign conditions, some are severe malignant type of conditions. So the causes we should understand, how to evaluate we should know. Emergency medicine, we get various complaints. One of the major complaint is palpitation. If you don't know the differential diagnosis, you will be in trouble. Most common cause for malignant condition which can produce palpitations are cardiac diseases. The cardiac diseases are the major cause for significant palpitation. That means the patient is having clinical finding with palpitation. All other palpitations mostly they are due to benign conditions or non-cardiac conditions. But some non-cardiac conditions are also having severe clinical problem like pheochromocytoma, hyperthyroidism, thyroid storm. They also can sometimes present with severe palpitation. Now the onset is very important. Some palpitations are continuous, like without any past history, some are with past history, some are without past history. Some are continuous for a long time, it will be there. Some are transient, within seconds it will start and it may last only for 1 or 2 minutes and it will subside. So many different types of palpitations are there. Some patients who is having sinus tachycardia, that means patient is having high degree fever, patient is having anxiety, patient is having fear. All these things you get sinus tachycardia. ECG wise sinus tachycardia means you should have a P wave, and in ECG there is a normal PR interval. Every P wave should follow by a QRS complex and RR interval should be equal. Then you can call it a sinus tachycardia and the patient is having tachycardia. Here the first ECG you can see P is there, PR interval is there, QRS complex are coming regularly and heart rate is somewhere around 100 beats per minute. So anything above 100 we call it as tachycardia. Any ECG is having PR interval, regular QRS complex, again we can call it as sinus tachycardia. So whether the sinus tachycardia is due to fever, pregnancy, anxiety, fear, whatever it is, sinus tachycardia is one of the common cause for palpitation. Some food items also can produce sinus tachycardia, like coffee. If you take more amount of coffee or coffee containing tablets, many tablets which has got coffee, caffeine, other adrenergic agents like phenylephrine, pseudoephedrine, like common cold tablets also can produce sinus tachycardia and palpitation. And sometimes this palpitation can be due to supraventricular rhythms or ventricular tachycardias. Supraventricular rhythm, you can see the first ECG is supraventricular tachycardia. It's a regular narrow complex tachycardia without P wave. So it is supraventricular tachycardia. You can simply tell it is a regular narrow complex tachycardia. That can produce palpitation. Second ECG, below that second ECG, that is called as multifocal atrial tachycardia. You can see different P waves in that. That is why it is called as multifocal atrial tachycardia. In a rhythm strip, if you are seeing more than 3 different types of P waves, you can tell the origin of the electrical activities from different foci in the atrium. So that's why we call it as multifocal atrial tachycardia. So since it is a tachycardia, you can get it you can get palpitation there also. The third rhythm on the upper part is atrial fibrillation, irregular QRS complex, that is atrial fibrillation. Then there is a wide complex tachycardia, you can see in the last ECG. There is a wide complex tachycardia. You can now you can think as VT. It has a VT. So there is difference between wide complex. There is a differential diagnosis for wide complex tachycardia as SVT with aberrancy and VT. Here the ECG is VT. So any types of supraventricular tachycardias, including atrial multifocal atrial tachycardia, atrial fibrillation, supraventricular tachycardia, all these things can produce palpitation. That is because the rapid heart rate, ventricle is beating in a rapid pace, like somebody is running, heart beats very fast, we feel palpitation. Like that, here due to some cardiac problem, heart is beating very fast and patient feels palpitation. But all these conditions, you have to ask one question: is the palpitation is regular or irregular? Irregularly irregular, any missed beats are there. So in here you can see supraventricular tachycardia, the palpitation will be regular. Multifocal atrial tachycardia, MAT, it is slightly irregular. Some ectopic beats patient can feel, but more or less it is regular tachycardia. Whereas atrial fibrillation, the palpitation will be irregular, and VT also it will be mostly regular, and patient can have hemodynamic compromise due to all these tachycardias. When the heart beats very fast, the pumping will come down, the diastolic phase will come down, and the systolic pumping also will come down. So patient can have features of instability like hypotension, chest pain, low GCS. All these things can be secondary to this rapid heart rate. Now, positional palpitation, some conditions you can see patient develops palpitation and syncope only in standing position. That is like many autonomic dysfunction conditions. On standing, heart rate either increases or decreases. If it is increasing, patient can get tachycardia. But there are some conditions, any position patient can develop tachycardia. One is atrioventricular nodal re-entry tachycardia. It's a type of supraventricular tachycardia. AVNRT or other types of tachycardias can be there in SVT. Whatever it is, if the heart rate is very high, that produces tachycardia. That is the problem here. So here you can see here in this ECG, there is rapid tachycardia, it is regular tachycardia, it is narrow complex tachycardia. So it has to be supraventricular tachycardia. In that, one of the major causes of supraventricular tachycardia is atrioventricular nodal re-entry tachycardia. So the classical finding in ECG will be there is no P wave, and P waves are normally hidden inside the QRS complex. Actually, P waves may be there, but P waves you are not seeing in the ECG because both atrium and ventricle are both atrium and ventricles are stimulated at same time. So P waves will occur during the QRS complex actually. Sometimes even after the QRS complex you can get, but classically AVNRT means you don't see the P wave. And because of this tachycardia, many patients experience pre-syncopal attacks. They have giddiness, dizziness, sometimes they develop syncope itself. That all due to tachycardia. When there is tachycardia, the diastolic phase will come down, so the filling will come down. That ultimately leads to reduced pumping. Patient develops hypotension and sometimes can produce syncope. Now, palpitation and syncope is very important. That has got a very important correlation because we already explained it in detail. When there is tachycardia, that produces palpitation. Because of the tachycardia, patient's diastolic phase will come down, patient's pumping will come down, then patient develops syncope. So many patients who is having palpitation can actually develop syncope. When we see the definition of syncope, patient loses his consciousness transiently and regains immediately after patient falling down. That means there is a transient reduction in the blood supply to the brain because of some cardiac issue or hypotension. When the patient falls down, this problem will be corrected, because when you are lying down, the blood which was not going on the standing position is now it is going to the brain on lying position. So immediately patient regains his consciousness. There are some conditions like generalized tonic-clonic seizures. There also patient feels palpitation, sweating, and patient suddenly loses his consciousness. But once the patient regains his consciousness, in GTCS there will be some confusion. That confusion is not there in syncopal attack. So post loss of consciousness confusion is not there in syncope, but it is there in GTCS. So that's how we differentiate these two conditions in emergency room. Otherwise, most of the clinical features, history and all will be similar. But syncope, one more history we can take is there is a pre-syncopal aura. Like before developing syncope, patient will have some lightheadedness, some vertigo-like features, some dizziness. Then suddenly patient loses his consciousness and regains very fast. Whereas in seizure, patient will not be able to give any history. Palpitation may be there, some sweating may be there, some aura may be there. Suddenly patient loses his consciousness. He will not be able to explain what happened during that phase. Now, medication history is very important. Patient, whether he is taking any sympathomimetic agent. I already told that there are a lot of over-the-counter drugs like cold medication that contains caffeine, that contains pseudoephedrine, that contains phenylephrine. All will increase the heart rate. There are some medications like beta blockers, diltiazem, verapamil, digoxin. They can produce bradycardia and they also produce palpitation and syncope. Anticholinergic drugs or withdrawal, sudden withdrawal from beta blocker, like patient is long term on beta blocker, suddenly due to some reason we stop beta blocker, suddenly there will be a reflex tachycardia, patient can have palpitation. So we have to be very careful when we are withdrawing beta blocker. Drugs like beta blocker cannot be withdrawn suddenly. We have to reduce the dose, slowly withdraw and see any symptoms are there or not. Now, one important condition which can present to emergency room with palpitation is hypoglycemia. Patients who is having hypoglycemic attacks, initially they can have palpitation, sweating, then suddenly they lose their consciousness. This is due to adrenergic drive during hypoglycemia. But we know that many patients who is having diabetes, who are on anti-diabetic medications, can already have a coronary artery disease, so they will be on beta blockers. When the patients are on beta blockers, when they develop hypoglycemia, all these adrenergic symptoms may not be there. They may not have palpitation, they may not have sweating. All these findings may be masked by beta blockers. So we have to be very careful in starting beta blockers in diabetic patients. Unless until there is a compelling indication like coronary artery disease, we should not start beta blocker, because not because the drug is producing any adverse effects in that patient. They can have a problem. That problem is hypoglycemia unawareness. That means in a patient who is having diabetes and on anti-diabetic drugs, if he is developing hypoglycemia, he can have loss of consciousness symptoms like palpitation, sweating and all. But if the patient is on beta blocker, all these symptoms can be masked. So if there is a compelling indication, start beta blocker. Otherwise, don't start beta blocker in a diabetic patient who is on drugs like oral hypoglycemic agents or insulin. It can mask the symptoms. That is called as hypoglycemia unawareness. That doesn't mean that we should not start beta blocker in diabetic patient. If there is an indication, we have to start. We have to advise the patient these are the problems can occur during treatment. Another important problem is pheochromocytoma. Patient can present with acute episodes of tachycardia, hypertension, cardiac failure in pheochromocytoma. So there also you can get palpitation. Thyrotoxicosis is one condition where the patient is having palpitation, weight loss, sweating. So normally we start beta blocker to control the symptoms in thyrotoxicosis, especially beta blocker like propranolol. So propranolol reduces the neuropsychiatric symptoms of thyrotoxicosis. Pheochromocytoma, we cannot start beta blocker as a first line drug. we have to start alpha blockers. Once the BP is controlled with alpha blockers, we can add beta blockers along with alpha blockers. So alpha blocker plus beta blocker. If you start beta blocker alone, that will produce unopposed action of alpha receptors, and BP can suddenly increase. So we have to be very careful in starting beta blocker as a first line drug in pheochromocytoma, but it can be started after the alpha blockade, initial alpha blockade. Now if you see the common causes for palpitation, you can divide that into non-cardiac and cardiac. Non-cardiac, physiological, we all know that exercise, anxiety, fear, pregnancy, so many physiological conditions which are very common in emergency room. Because of fear itself, patient can have severe palpitation, chest pain, angina like symptoms, all these things. Pathological, fever, anemia, thyrotoxicosis, hypoglycemia, drugs like salbutamol that I didn't tell in the previous slide. Salbutamol is one of the most common drug we use for breathlessness in emergency room. One of the major side effect of salbutamol is tachycardia and palpitation. So in many patients you can experience, they experience palpitation, tremors, all these things because of salbutamol. So in that case, we cannot use salbutamol, we have to use ipratropium bromide, that is slightly different from salbutamol. If the patient is having adverse effects due to that drug, we can use ipratropium bromide. Then cardiovascular conditions, we have already seen some. All supraventricular tachycardias like SVT, atrial fibrillation, multifocal atrial tachycardia, ischemic heart disease, hypertensive heart disease, cardiomyopathies, valvular heart disease, mainly MVP, MR, MS, AR. MVP is not a major lesion in the heart, but patient can have neuropsychiatric symptoms due to this MVP. Patient can have palpitation, sweating, anxiety, fear, all these things are associated with MVP. Beta blocker is the choice here in MVP related palpitation. Pheochromocytoma we already seen. Another important problem is ectopic beats that we didn't discuss in the previous slide. Ectopic beats mean ventricular ectopics, not really atrial ectopic. Ventricular ectopics can produce palpitation in many patients, that they feel it as a missed beat. Actually, other palpitations, the heart is beating very fast in SVT or atrial fibrillation. Here, palpitation patient will describe as missed beat. Only they will feel the missed beat. What happens is, when there is a missed beat, they will feel that heart is not beating, and the second beat will be more forceful. That is a problem. So, for the missing beat, they may experience that there is a beat missed. Why they are experiencing that? The next beat will be more forceful because the first beat, which was ectopic, has not pumped properly. That blood is remaining in the ventricle, and some more blood is coming to the ventricle, and the beat after this missed beat will be more forceful. That patient will notice. So a missed beat and forced next beat patient may notice, and if it is repeatedly coming, patient will tell that repeated missed beats and a forceful beat. So here you can see the ECG. First ECG 1, 2, 3 are normal QRS complex, but fourth QRS complex, which is wide QRS complex, which has come much earlier than the regular beat, that is a missed beat. And second ECG also, third beat is a missed beat. Third ECG, first row, that is lead 3, you can see there is fourth beat is a missed beat, fifth is a normal QRS complex, next also missed beat. So 2 missed beats coming in a row. In a row means alternatively. So by Gemini it is called. Okay. So the patient may tell that alternatively I am getting missed beats. So when we are taking clinical clues, clinical history, you can get some clues from the history. If the patient is very intelligent, he can tell all this history. But most of the time in emergency room, this patient will have anxiety, fear, so they may not be able to explain everything in detail. But you can ask the history of all these things, whether it is a single skipped beat with dyspnea, rapid regular palpitation, rapid irregular palpitation, exertional palpitation, anxiety with palpitation tremors, heat intolerance, tall thin individuals. So all these conditions, like all these histories or clinical examination findings will give a clue towards what is the problem in the patient. Now once you get a patient who is having palpitation, you have to do some investigation. The most important investigation will be hypoglycemia, can be ruled out by a GRBS. You do a glucometer RBS. Then thyroid function is very important to rule out hyperthyroidism. ECG should be done to see what is the rhythm problem. TMT can be done in patients who is having some rhythm abnormalities. To rule out ischemic heart disease, you can do TMT. Echo should be done whether any regional valve motion abnormality is there, whereas any other cardiac lesions are there, MVP is there, all these things you can do ECG also. There is a condition which is a autonomic dysfunction, postural orthostatic tachycardia syndrome. It's a type of autonomic dysfunction when the patient stands up. Initially, normally we can see in many diabetic patients, when the patient stands up, the BP may reduce on standing up. This is called as postural hypotension. But in some patients, postural hypotension will not occur, but to compensate that, heart rate increases. So many patients who is having postural orthostatic tachycardia syndrome, so on standing the heart rate increases. That's all. BP may not fall down. That may be the second phase of the disease. So it's a different type of disease. Only there is increased heart rate, then hypotension occurs. But here only heart rate increases. So during that phase, patient also may feel palpitation. So this can be diagnosed by a test which is called as head-up tilt test, HUT test. So that can be done in patients who is having postural tachycardia. Now, electrophysiology study and Holter monitoring should be done in a patient who is having transient paroxysmal tachycardia. Some patients may tell, I have tachycardia during yesterday evening 5 o'clock, but after that I was normal. In that case, when you are taking an ECG, you may not see anything. When you are doing a TMT also, you may not see anything. So after proper history taking, after proper examination, ECG finding, then you can ask the patient to go for a Holter monitoring. 24 hours we have to monitor the heart rate. In that while monitoring, you can see some patients can have transient tachycardias, transient bradycardias, transient complete asystole. All these things can be seen in patients who is having Holter monitoring. And electrophysiology study also done in some patients who is having other unexplained syncopes or unexplained palpitations. Now this is a chart which explains you how to manage the tachycardias. I am not going to tell all these things because we have explained all these things in various other classes. But however, you have to see this chart and see how to treat the patients who is having a significant tachycardia. Significant tachycardia means patient who is having tachycardia with shock, hypotension, syncope, myocardial ischemia, heart failure, low GCS. All these things are significant tachycardia. In that case, you have to go for shock, and if the patient is fully stable with tachycardia, you have to see whether it is a narrow complex or broad complex tachycardia. Both these conditions, one drug will be common. You can find out from this chart, one drug is common for all this group, all this type of patient, that is amiodarone. So if you know it properly, what is the rhythm, if you can diagnose whether it is SVT or whether it is atrial fibrillation, you can go for amiodarone or beta blocker or adenosine, whatever it is. But if you don't know anything, if you are not able to diagnose anything, then you can go for one drug, that is amiodarone. But for that also, you need to know about the drug, you need to read about the drug. I am not discussing all these things here, but this chart may be helpful for you. So we have discussed one of the most common clinical problem in emergency room, that is palpitation. There are a lot of conditions which can produce palpitation. Some are very benign conditions like anxiety, fear, coffee, excess tea, some recreational drugs, and some are very dangerous conditions like cardiac failure, pheochromocytomas, hypertensive emergencies. So detailed history may pick up some of the differential diagnosis, but we have to be very careful that some diseases cannot be picked up without detailed history. take a detailed history, examine the patient in detail, and do some basic investigations, ECG, echo, some thyroid function test. All these things will definitely give you a clinical clue. And you also should know how to manage the condition, because most of the time this tachycardia is due to, these palpitations are due to tachycardia, whether it is narrow complex, regular, irregular. If you follow up the ACLS protocols, you can easily manage the condition. But conditions like pheochromocytoma, thyrotoxicosis, all these things require additional level of management. That also you should be very careful. That's about palpitation in emergency room. Thank you.